Welcome, Dr. Raja.
Thank you. Thank you, Team Nadia, for asking me to talk on the topic. And you just heard two brilliant lectures, and you have a formidable benchmark for me to accomplish. So, in all fairness, membranous nephropathy is the only adult primary glomerular disease where we have good investigator-initiated clinical trials which have informed decision-making process. I am not aware of any other glomerular disease where you have such trials which have looked at 1 decade of follow-up. You have one start trial, IGA Nephropathy, but again that's a negative study and it's still confusing. So what are the questions pertinent to the topic? The questions is, why do we need to stratify membranous nephropathy? One, what is the current evidence for the immunosuppressive therapies in membranous nephropathy? What are the newer drugs in pipeline? And what are the key points in managing membranous nephropathy? So we all know that not all membranous nephropathy are the same. Some do not merit immunosuppressive treatment. Some merit aggressive immunosuppression. This stratification is based on proteinuria, serum albumin, PLA2R antibodies. In certain Scandinavian countries, there are certain urinary markers which are available. I think that is not relevant to most of them. So based on this, we are stratified as mild, moderate, severe, and very severe. Mild essentially means subnephrotic syndrome. Moderate means having a nephrotic syndrome, but the serum albumin is reasonably low. Severe means you have a proteinuria of over 8 grams, or you have a serum proteinuria of more than 3.5 grams, but have severe hypoalbuminemia or have an anti-PLA2R of over. Very severe essentially means you have an RPR, like presentation, or somebody who presents with multiple infections, or somebody who has developed the venous or arterial. So there are at least 4 scenarios in membranous nephropathy. One, you could have a middle-aged gentleman or lady presenting with nephrotic syndrome with low PLA2R titers. 2, you could have a similar nephrotic syndrome with high PLA2R titers. High and low essentially means less than 150 is reasonably okay, more than 150 is high PLA2R titers. Third is you have somebody with biopsy-proven nephrotic syndrome that also has a persistent kidney dysfunction, not one associated with nephrotic syndrome, but as having a persistent kidney dysfunction, about 2 to 3 milligrams per deciliter. The fourth one is you have somebody who is resistant to multiple sources of immunosuppression. So these are the 4 scenarios. I think you have a transplant situation. We can do it for the discussion. So the 2011 or 12 KDIGO guidelines suggested that patients with membranous nephropathy who are refractory to ACAR need to be treated with a cyclical cyclophosphamide. This is the evidence from 2 clinical trials, one from Italy and one from India by R. Virendra, where they looked at supportive care alone or supportive care along with cyclophosphamide and corticosteroids given in alternate months. And what they found was not only there was a mathematical difference, but there was an emotional difference between the outcomes between the 2 groups. 3/4 of the patients had either complete or partial remission at the end of 10 years, versus only 1/3 of the patients who received support. Again, you see doubling of serum creatinine, dialysis requirements, or death are way more frequent in patients who receive supportive care alone compared to immunosuppression. This forms the basis for recommending cyclical cyclophosphamide and corticosteroids as the first line therapy. In the last 3 decades, we yet don't have a drug which outperforms this. But there are certain sore points which use cyclical cyclophosphamide and corticosteroids. If you take a 60 kg man, the amount of corticosteroids used for its membranous nephropathy, it's not membranous glomerulonephritis. So you don't have inflammation. The creatinine is largely normal in 80 to 90% of the patients. but the amount of corticosteroids that we use is highest among any glomerular disease and or vasculitis or even transplant. For transplant rejection, we don't use this kind of dose. It's about 13.5 grams. I've converted the methylprednisolone dosage to prednisolone dosage. 5 grams of corticosteroids and 13.5 grams of cyclophosphamide. 13.5 grams of cyclophosphamide is not life-threatening. You don't develop cancer with this dose, but yes, it can be given. And other is the poor quality of life. You can have cosmetic effects. And when you stop corticosteroid at the end of 1, 3, and 5 months, the patient starts to develop corticosteroid withdrawal. There is anorexia, weakness, and problem is they attribute it to cyclophosphamide and they reduce the dose of stop cyclophosphamide. This is in 30% of it. And also we need to remember that only 40% of the patients in India, when they say that they give cyclophosphamide and corticosteroids, receive the classical quantity. Otherwise, there are multiple modifications to the modified quantity. It's 1/3 in the world, it's 40%. So coming to the roadmap of the recent clinical trials, there are at least 5 clinical trials. One trial which we did about 10 years ago, then the rest 4 are rituximab. Our study was a negative study which primarily compared tacrolimus and corticosteroids versus the modified quantity. To cut the long story short, the final word is cyclophosphamide and corticosteroid is superior to CNI. They may be having the same efficacy at the end of the year, but after that there is a divergence in the remission. It's mainly because of the increased relapses that occur with CNI. So if you use CNI, it is just like kicking the can down the road. You'll have remission today, but inevitably at the end of it, you will have a relapse coming back. So next 4 trials are rituximab trial. 1, the Gemritix trial, which looks at rituximab versus the supportive care. 2 is the Mentor study, which was rituximab versus cyclosporine. The third is Harman trial, which looked at a sequential therapy where they gave CNIs for 6 months and then gave 1 shot of rituximab. The last is the Pirate study, which is a Ricyclo study. There is also a 5th Indian study which is by the Post Institute, which was done by Sandhya Suresh. I will discuss those studies. The first study is the Gemritix trial, which looked at supportive care versus 2 shots of rituximab on day 0 and day 8. And they looked at the complete or partial remission at the end of 6 months. And when they looked at complete or partial remission at the end of 6 months, there was no much difference between the rituximab arm and the supportive. However, if you look at the anti-PLA2R, there was a good reduction in anti-PLA2R in the rituximab arm compared to the supportive. And when they extended the clinical follow-up to 17 months, what they found was 2/3 of the patients treated with rituximab responded. There is only 1/3 of the patients who receive supportive. The conclusion is PLA2R antibody is an early marker of disease activity. You need to incorporate it in your clinical practice. 2, rituximab induced clinical remission happens after that time. So 6 months is never a time to look into remission. The next is the Mentor study, which is published in New England Journal, where they compared rituximab with cyclosporine and have reservations about the use of cyclosporine because it's never a primary therapy when educated or cell diagnosis. But yes, what the authors found was at the end of a year, rituximab was not inferior to cyclosporine. And at the end of 2 years, rituximab was superior to cyclosporine in inducing remission in patients with moderate. Also, an important thing to note is the side effect profile, though was not statistically significant, was favorable in patients treated with rituximab compared to cyclosporine. So, rituximab, the bottom line is rituximab is better than cyclosporine in managing disease. The third is the Harman trial, which is sequentially they gave CNIs, that is tacrolimus, for 6 months. They believe that if you use, there is a functional effect, there is a reduction in proteinuria. Then you give 1 shot of rituximab, get the B cell depleted. So there is a synergetic effect. So this is what the hypothesis was. And they compared it to the modified quantity. And what they found was modified quantity was superior to the sequential therapy. More than 80% of the patients had either complete or partial remission in the modified quantity arm versus only 58% in patients treated with the sequential therapy. Also, the complete remission rate, if you look at 60%, this versus only 1/4 of the patients treated with sequential therapy. The antibody reduction was also very significant in patients treated with modified quantity with the rituximab-based therapy. And the side effect profile was also comparable to both the groups. The summary is modified quantity is better than the sequential therapy. The last study is the recyclo study, which is, rituximab. They gave rituximab 1 gram on day 0 and day 2 and compared it to the modified quantity. What they found was at the end of a year, the 3/4 of the patients treated with the modified quantity protocol achieved remission versus only 62% of the patients treated with rituximab. But yes, that's fine. The difference was not statistically significant. The complete remission rate, yes, was certainly higher in patients treated with cyclophosphamide and corticosteroids, but the difference was not statistically significant. Surprisingly, the relapse rate was higher with the quantitative protocol compared to rituximab treated patients. And the side effect profile was just a mirror image of the starting trial. The conclusion was the pilot study suggested that the study is feasible and there is no signal of more benefit or less harm with rituximab compared to and corticosteroids. I would fail in my duty if I don't show the study because it's our duty to promote Indian studies. So this is a study which is done from this institute where they compared 68 patients equally divided to rituximab in the modified quantity arm. Rituximab was a low dose, 500 milligrams given on day 0 and day 15, and they looked at remission rate and index. What they concluded was 50% of the patients treated with the quantitative protocol responded at 6 months, and about 70% of the patients treated with the quantitative protocol responded at 12 months, compared to 44% and 60% at 6 and 12 months in the rituximab. And the side effect profile was favorable in the rituximab patients. So the conclusion is, this being a pilot study, it shows there is a feasibility, and there is the short-term data at least suggests that there is a comparable efficacy between both the groups. So if I have to draw a summary of all the studies, it suggests that rituximab is superior to supportive care alone or CMI in nephrotic control. Rituximab may be as good as cyclical cyclophosphamide and corticosteroids in managing membranous nephropathy. And many people say maybe as not. Again, that's a debate. So, and rituximab induced remission happens after 6 months and it will grow over time. You will never have any more rituximab based randomized clinical trials because you are graduated to the next B-cell. So next is about titer and kidney disease. So titer, there is a general tendency to believe that high titers, the patients are poorer prognosis irrespective of what treatment you do. Even if you treat with modified quantity, patients with high titers will have lower remission compared to those with low. It suggests that it's more severe. So this is a study which was a comparison of the Paris and the 9 million of the Netherlands, where close to 100 patients, 50 is the Gemritux cohort, and 50 is the 9 AM cyclical cyclophosphamide and corticosteroid. Here they give cyclophosphamide and corticosteroid for 6 to 12 months. So the dose of steroid is almost double as the modified quantity, and also the cyclophosphamide is double as compared to the quantity protocol. So what they found was at the end of 6 months, in patients with antibody titer of more than 152 reference units per ml, 24 of patients treated with rituximab had remission, compared to over 80% of the patients treated with cyclophosphamide and corticosteroid. The conclusion was, if you have a high anti-PLA2R titer, cyclophosphamide and steroid is better than rituximab. So what the authors did was, they gave a booster dosing in the subsequent patients at in between month 3 and month 4. And what they found was, giving a booster dose or an additional dose, whatever you call it, it brought about increased immunological remission and subsequent clinical remission in these patients, suggesting that add an additional dose in between 3 to 4 months, it facilitates immunological remission and again, yes, clinical remission as well. So, this is a study which we published in Kidney Function Report a couple of years ago, where 66 patients, 33 of them high PLA2R titers, treated with rituximab, and we compared them with similar patients treated with the Ponticelli protocol. And the rituximab was all CD19. Most of the patients received the third month dosing. The proteinuria was comparable. The PLA2R antibody did not have any significant difference between the two groups. The remission rates were also comparable, although numerically they looked the Ponticelli protocol being better than the rituximab, but it was not statistically significant. But yes, the adverse events were more commoner in patients with cyclophosphamide and cyclophosphamide, but they were all minor events. And if you compare the severe events, there were not differences between both the groups. So the next is about patients with kidney dysfunction. In patients with kidney dysfunction, what we know clearly is alkylating agents with corticosteroids is superior to cyclosporine and supportive. This is a study published in Lancet a decade ago. It's one of the best studies done in membranous nephropathy, where they had to enroll patients for 10 years to get that numbers. Then, and also, because we know that cyclophosphamide and corticosteroid work, what about rituximab? So there is emerging evidence that rituximab is also useful in patients with severe CKD. Severe CKD means CKD, 4 and 5. So this is a study of 13 patients published in international reports from the Paris cohort, where they gave either the gemcitabine protocol or the NICE protocol. We call it the NICE protocol, 1 gram on day 0 on day 15. And what they found was, there was a 90% reduction in proteinuria, the serum albumin, it returned to normal, and also the GFR improved in the patient, suggesting that rituximab is effective and also safe in patients with membranous nephropathy with severe CKD. So this is our experience of 16 cases where we treated these patients with more of CD19 targeted therapy, and a few of them received 1 gram on day 0 on day 15. There was a reduction in proteinuria by over 50%. There was close to doubling of serum albumin, and also there was a reduction in serum creatinine, suggesting that rituximab may have a role in patients with severe CKD and membranous nephropathy. So what about resistant membranous nephropathy? That's the last part. So, there is always a debate about defining the resistance. What is not debatable is persistent nephropathy. What is debatable is the timeline. Somebody says 6, somebody says 9, somebody says 12. But what is widely accepted is about 9 to 12 months of starting therapy. If your patient does not respond, you may call it as resistant membranous nephropathy. Yes, PLA2R has made us more wiser. So if a patient who was initially positive has become negative, you can wait for an extended period of time. But if somebody was not turned negative, there is only a reduction in anti-PLA2R. It would be wise to consider them as a resistant disease and plan the second line therapies. So, what are the evidence? The first is tacrolimus, which is used in patients treated with cyclophosphamide. Most of the resistant nephropathy evidence comes from our unit. Tacrolimus, it has some functional effect. Like I said, it's keeping the can down the road, does not bring about immunological remission. Cyclophosphamide, yes, works in 3/4 of the patients, brings about immunological and clinical remission. Rituximab, slightly less, but yes, brings about immunological and clinical remission in 50 to 60% of the patients. Obinutuzumab is a new kid in the block. So it brings about deeper and longer B-cell depletion. Deeper in the sense that it also depletes B-cells in the other organs, and also longer periods of B-cell depletion as compared to rituximab. This is well proven in patients treated with CF. 70 to 80% of the patients who are treated with obinutuzumab achieve remission despite multiple tests of immunosuppressive therapies. Then there are anecdotal reports of using ACTH, bortezomib, daratumab in patients with resistant membrane. There is a new approach which is using a hybrid of cyclophosphamide, corticosteroid, and rituximab. They use smaller dose of cyclophosphamide and corticosteroid and use larger dose of rituximab, and you want to see the remission rates. So the other is looking at the antibodies in patients treated with rituximab and how do they perform if they develop relapses. This is our report along with the French group, where we looked at anti-rituximab antibodies. So anti-rituximab antibodies is there in about 1/3 of the patients whom we give, adult patients whom we give rituximab therapy. And the significance of it is not known. In skin conditions, it is very clear that they are not known. Whereas we don't know what is its significance in patients with membranous nephropathy. And what we found that when these patients developed relapses, when they were treated with rituximab, they did not do so well compared to OD or ofatumumab. So, maybe obinutuzumab or ofatumumab is better than rituximab in patients who develop anti-fungal antibodies. So, as Dr. Aditi had already suggested that, ofatumumab is a complete humanized and obinutuzumab is humanized, like it's better than rituximab, but still has some other components. So, coming to the hybrid therapy, this is a study which is published from the Harvard University. There were 60 cases. They followed up over 5 years. 1/3 of them were relapsing and 15% were, resistant disease. Another 15% was treatment-naive disease. Anti-PLA2 or titers were 1, and 100% of the patients treated with this regimen responded clinically and had a So there's nothing to debate about. And it was reasonably safe. What you need to look at is, the rituximab used was 8 grams, that is 0, 15, 4 months, and every 4 months to 18 months, they had used rituximab. So the huge dose of rituximab that was used in this therapy. So, we looked at, we gave a similar regimen to our patients. About 20 odd patients where 1/3 were relapsing, but, 2/3 of them had resistant disease. The PLA2 or titers were about less than what was reported in the US paper. But what we found was immunological remission was higher, but only 2/3 of the patients had a infection. One reason is most of our patients had a long vintage of the disease, so there was chronic fatigue. We did biopsy these patients. Many of them had diffuse glomerulonephritis. So if you have diffuse glomerulonephritis, you will have nephrotic proteinuria with a preserved serum margin. This is on the record. So essentially, they are all stable. So this is a regimen that we can find out. So this is the use of a similar regimen with shorter course of corticosteroid. They use it only for about 3 weeks. 1 week 1 milligram, then 0.5 milligram, then 0.25 milligram stop, along with cyclophosphamide and rituximab in treatment-naive patients. What they found was at the end of 2 months, 88% of the patients achieved immunological remission, and at the end of 6 months, 80% of the patients had clinical remission. So this is very effective solution with treatment-naive. So what is the changing paradigm of membranous nephropathy? So there are at least 2, set of targets. One is the B cell, plasma cell, that group, and the other is about the complement. So, if you look at membranous nephropathy, you will have 2 patients. One, you have an anti-PLA2 or titer of 50, you get it down to 10, and you have treated with modified quantity and they have complete remission. You have similar 50 to 10, you treat them with rituximab and they come down to a proteinuria of about 1 to 1.5. Membranous nephropathy is 2 set of disease isolates. One is development of antibodies, and next is what the antibodies does in the renal space. That is, they develop immune complex, activate complement. It could be very much possible that we inhibit the antibody generation. And complement is activated may go on. That is why you have many patients with membranous nephropathy who achieve immunological remission still continue to have nephrotic state. It could be because of the activation of complement. Maybe this group of patients an anti-complement therapy. That's why your steroid is very helpful, because steroid has got anti-complement activity in the kidney. That is why you will find more complete remission patients. So, what is the new kid in the block is obinutuzumab. It's something which we need to look up to. Obinutuzumab is clearly superior to rituximab. This is the evidence that we know from the the CLL data published in New England Journal of Medicine. And here there is a Chinese report. Chinese, they have a printing press. Every 2 weeks they have a paper on membranous nephropathy. So 21 patients, they did a propensity match scoring with 40 odd patients treated with rituximab, and what they found was more than 90% of the patients had complete or partial remission when treated with obinutuzumab, vis-a-vis only 2/3 of the patients. I think 2/3 response with rituximab has been seen in every part of the world. But with respect to obinutuzumab, we need to look up. Immunological remission also has seen in more than 90% of the patients treated with obinutuzumab compared to 60%, suggesting that obinutuzumab is something to watch for the future. And there are various clinical trials which are actually going on in this space. So they are the Majesty trial, which is headed by the Mayo Clinic, where they look at obinutuzumab versus Tacrolimus therapy. In mentor, they use cyclosporine, and I think after criticism, they have graduated to tacrolimus. I think the enrollment is over. We are looking at the results now. The next is the REMIT trial, which is sponsored by the ATIN network, and the national lead, where we are comparing obinutuzumab with cyclophosphamide and corticosteroids. This is yet to start. This is transplant. Then we have REBOOT trial, which is looking at belimumab along with rituximab versus placebo with rituximab in patients with membranous nephropathy. Then we have fewer trials looking at the complements. The main is iptacopan, which is the complement factor B inhibitor, which is looking at iptacopan versus rituximab in membranous nephropathy. These are the clinical trials in five. So before I conclude, that another thing that we need to be mindful of is anticoagulation in patients with membranous nephropathy. Glomerular disease patients are at heightened risk of developing thrombosis, and among all the glomerular disease, membranous nephropathy carries the highest risk. And low serum albumin is the best predictor of developing thrombosis, and the bitter spot is about 2.8. If you have a serum albumin of less than 2.8, you are at a higher risk of developing thrombosis compared to those who have a serum albumin of over 2.8. So there are concerns of monitoring, bleeding risk is always there. And there is a debate whether you use a vitamin K antagonist or you use a non-vitamin K antagonist. I think emerging evidence suggests that you can use a non-vitamin K antagonist comfortably as a primary prophylaxis. But if somebody develops thrombosis, it is better to use vitamin K antagonist. There is a risk balance. And the bottom line on anticoagulation, we should anticoagulate all the patients with severe hypoalbuminemia with low bleeding. So my last slide is about the 10 points that you need to be mindful in managing membranous nephropathy. One is conservative. We always waited for 6 months, although many did not choose to wait, but the consensus said that we need to wait. But with anti-PLA2R and high anti-PLA2R titer is less likely to achieve spontaneous remission. You can treat them upfront without waiting. Second, anti-PLA2R in membranous nephropathy has a major role in practice. You need to do them at the start and at 3 months and at 6 months. If you are getting rid of the biopsies, it would be better to do indirect immunofluorescence. But for therapy monitoring, you will require ELISA testing, because ELISA testing gives you a value. You can find a reduction in the PLA2R titer. And if the PLA2R titers are positive and patient has nephrosis syndrome, you should go to the next line therapy after 9 to 12 months of the primary therapy. In patients with membranous nephropathy with severe CKD, unlike IGA nephropathy or FLCS, there is a merit in treating patients with severe CKD. They do respond. You can delay the progression to end-stage kidney. Malignancy with cyclophosphamide is an overinflated entity. It is more of infertility which is the issue, not the malignancy. With the modified Ponticelli dose, malignancy is seen when cross 35 grams of in the traditional modified Ponticelli, you give about 30 minutes. Fertility, as I said, fertility is a serious issue. The patient is married and wishes to have kids. I think we should choose an alternative regimen or low dose cyclophosphamide. Anticoagulation, I just said, all patients with severe hypoalbuminemia and low bleeding risk need to get anticoagulation. Additional rituximab, 2 doses of rituximab doesn't help. You need to give a third dose in between 3rd and 4th month, at least in patients who have anti-PLA2R positivity. It increases the chance of achieving clinical remission. Corticosteroid withdrawal in modified Ponticelli regimen is a serious issue. Many patients reduce the dose of cyclophosphamide because they falsely attribute to cyclophosphamide. And make sure that you give pneumocystis prophylaxis to all your patients, because all patients should receive Cephalon, irrespective of whether they receive rituximab or cyclical cyclophosphamide and corticosteroid. And vaccination, make sure you vaccinate all patients for hepatitis B, and the addition is a zoster now. And the COVID time. With this, I will stop and I'll be happy to take questions.
Excellent talk. Sir, when we are doing this study here, the efficacy of rituximab is in CD19 level. Even a single dose of 500 milligrams of rituximab makes every person get the CD19 low enough. So, that people say that the 1 gram, 2 grams, 1 gram every 4 weeks what are we trying to achieve here is the final efficacy of the drug, and we don't know the effect at least for 6 months. How do you look at it?
Yeah, you asked me that. So, we published maybe 6-7 years ago, we published a report of 6 patients where we gave only 100 milligrams of rituximab. All the patients achieved, CD19 reduction. Just like ABO incompatible transfusion, we give 100 milligrams. Most of them would at least achieve, CD19 depletion. But they have a repopulation which happens very quickly. One. Unlike ABO incompatible, where you don't lose rituximab in urine, you're going to lose a lot of rituximab. Whatever rituximab you give, 80 to 90% of them will go down the urine within the next 24 hours. So, there will be repopulation which will happen very quickly. And, unlike obinutuzumab, rituximab will only deplete the B cells, which is in the vascular system, not the extra. So that is why. So when we looked at, we did achieve remission at the end of 12 months, but what we found out, most of these patients had relapses immediately after 12 months, suggesting that, there was a depletion, there was an antibody reduction, but when the cells populated, there was a relapse. I don't think it's a good idea. So coming to your question, there have been comparisons about the NICE protocol where they use 1 gram on day 0 and day 15 versus the Gemrutix protocol, where they found that, in the Gemrutix protocol, only 50% had a depletion of anti-PLA2R at the end of 6 months, whereas in the NICE's protocol, where they use 1 gram on day 0 and day 15, they had 70%, anti-PLA2R immunological remission at the end of 6 months, suggesting that the more, the better it is. Because whatever rituximab we give today, it will go down the urine. So circulating rituximab will not be there. That is, we use CD19 as a surrogate for circulating rituximab levels, but it can, suddenly it can, repopulate. Repopulate is not repopulating to the full cell. If it's just more than 5 cells, we call it as repopulation. That much should be more than. So, I think the current standard is to give 1 gram on day 0 and day 15. At 3rd month, you will need to give the patient continues to have nephrotic syndrome or the PLA2R is positive.
Memory cells have less restriction which target. Hence, the depletion of memory cells is less so in the lower. Again, what we have shown now is that when we actually look at the tissue level, actually they are in the 8 to the 24 percent. Even though the cells are and hence I think the high doses
Yeah. Most of this evidence comes from anti-vaccines. So that's why I said deeper remission is there with obinutuzumab, but not with rituximab. So that is why you see that 90% remission rate consistently with obinutuzumab. That's not seen with rituximab. Your point is well taken, and it's actually one of the first reasons for why rituximab. 40% of the membranous nephropathy have resistant disease with rituximab. The first reason mentioned. I think it's a very good question, and we have graduated to using Apixaban 2.5 milligram BD. We don't use vitamin K antagonists as primary prophylaxis. Main reason is, one is the monitoring becomes very difficult. Patients with nephrotic syndrome, they need to come multiple times before their INR is set. And second one is, in North India, they eat a lot of greens. It's very difficult for them. So the average dose of warfarin for having an anticoagulation is 8 milligrams. And we start at 2 to 3 milligrams. And to get 8 milligrams, it takes about 2 to 3 months to actually reach that. And many of times when you call a patient after a week, they don't come after a week. They come after 2 to 3 weeks. So we have moved to Apixaban as the primary. Yeah. This is an always asked question. See, why Ponticelli choose this kind of regimen? I don't think he also knows. And he said that I choose the regimen because the patient is on one immunosuppression at one point of time. So I don't think that's right. If you stop steroid today, the effect of steroid will be there for the next 1 to 2 months. Coming to whether you can use a combination of cyclophosphamide and corticosteroid, like they use in previously they used to use in vasculitis, I think the answer is overwhelming yes. In Australia and in many parts, they use a combination of oral and oral corticosteroids and cyclophosphamide. In the 9 AM protocol is like, they use oral corticosteroids and cyclophosphamide simultaneously, not like alternating. And yes, if you use them simultaneously, I think it will be better because you don't stop any steroids abruptly. But again, why Pondicherry is recommended is because the guidelines look at evidence, and evidence is only available with Pondicherry. So that is the reason. I don't think any other reason. Map, you would have received that. It's an industry sponsored by Roche. So when you want to fight a war, you choose the weakest opponent. They have completed the recruitment because Roche is pushing it, right? Like, the map also, they're ready to pay a lot of money for a single patient. They will pay up to maybe 7 to 10 lakhs. So, they are trying to, you will obviously choose a weaker. So, the protocol that we are looking at remedies, where we are looking at cyclophosphamide versus, the obinutuzumab, Roche is having issues.
I think the US is having more of a natural limit as compared to the Europe. Europe use more cyclophosphamide, US use more lateral limit. I don't know whether they are afraid of infection, but again, the efficacy is very good and the side effects are manageable. So, even though we use, then it is cheaper as compared to infection. And you said that the steroid withdrawal and there is reduced the functionally necessary translating agent. Whether you add on a small dose of 5 mg, 10 mg, whether your side effects is reduced and you will be able to complete the course properly.
I think, again, if you reassure patients, generally they accept that it's because of the steroid withdrawal, their hunger goes down. But it's only a small minority that, you may have to curtail the therapy and give them, you may have to taper corticosteroids. But the problem is, you taper corticosteroids, by the time you taper them, they are ready for the next month of full 1 gram or 3 grams of therapy. Drastically. We had one mother who came and told, give any costly medication because he's eating 60 chapati. So I think it is very difficult. 2020 is difficult for even expensive regimen.
Sir, Dr. Shubho here. So, do you think these intermittent pulses that we're giving on the first, third, and fifth month are always necessary, or can we cut down on the dose because that kind of adds on to a?
I will show our results. So our results is under revision. So where we looked at the clinical trial of 114 patients. So where 57 received the modified Pondicherry protocol and 57 of them received the without pulses, only 0.5 milligrams of corticosteroids and half the dose of cyclophosphamide. And 80% remission was observed in both the groups. I think I'll just hide this slide because it will just come back for revision.
So what is your current practice? You are actually giving 1 gram pulses to a general, when you are opting for a modified quantity, do you actually give 1 gram pulses?
No. We follow the modified quantity.
To the letter?
We generally follow the Italian very closely.
Mason, last question. Therapy for a non-plateauer, plateauer negative membranous when you want to immunosuppress, what is your first choice? Either CNI or a
CLA2 or antibody is negative. But if this CLA2 are related, if the tissue is positive, then there could be two chances. One is a zinc phenomenon, or other is the patient has achieved immunological remission and you have to wait for some more. So in these patients, I think merits you need to wait for some more time
both
before
negative
deciding therapy. If it is non-PLA2 or related, then you look at whether there is history of therapy, complementary medicine, and others. If there is none, I think I would choose to treat after 3 months of it.
And then what will you choose? Pondicherry based?
Pondicherry, or there are many factors that we choose. Previously, money was an issue, but now after Ayushman Bharat, it's never an issue. But yes, our tendency is to use modified Pondicherry.
Because there are very few data for plateau negative and native.